Shall we start right on time? It's nice when you're chairing a conference when things run so on time, so much on time, and today that's happening. Welcome to our panel on health systems policy. My name is Kevin Stoddart, and I'm pleased to moderate the panel. And each panelist will present their views on health systems policy, and we're really wanting to look at various levels of health system policy that will start actually from a national point of view and move into a provincial point of view. But I also want us to consider organizations and communities as well. So briefly to introduce our panelists, Ms. Margaret Whalen is board member of the Canadian ASD Alliance. They're in order. They're very compliant today, so thank you, panelists. Dr. Ian Daw is physician-in-chief at the Ontario Shores Centre for Mental Health Sciences. Margaret Spolstra is executive director of Autism Ontario. Dr. Susan Farrell is clinical director of the Community Mental Health Program at the Royal Ottawa Health Care Group. And finally, Ms. Jane Cousins is Senior Policy Advisor, Universities Unit, Ministry of Training, Colleges and Universities. Welcome, everybody. Applause is appropriate, I think. Before I ask the panelists to discuss their perspectives on policy in adults with ASD, I'd like to make three introductory points which are important cornerstones, I feel, in our consideration of policy development and transformation in Ontario and across Canada. First, it's important to acknowledge the needs of youth and adults living with ASD are widely heterogeneous, multiple, and clinically complex in nature. Therefore, multiple service and support systems must be involved in their care. This includes adult mental health providers, autism specialists, medical practitioners, income maintenance programs, employment programs, and high schools, colleges, and universities. Systems need to talk to each other, especially at times of patient transition. This need for cross-systems communication is not unique to ASD, but is especially important for this group, their families, and their service providers. One of the recommendations that we made in our 2013 study of 480 youth and adults in Ontario was that ministries, organizations, and networks at regional, local, and provincial levels must actively engage in conversations in existing forums to increase service integration, identify systems deficiencies, and collaboratively develop strategies. In that study, we consistently heard from adults and their families that services and supports in the province are becoming more difficult to access, that the existing system is fragmented, and that the transition to adult services is a very stressful one. We also learned that medical and other specialist practitioners were difficult to find, even in cities, but especially in rural communities. Second, Ontario is not policy ready for the current needs or further influx of individuals living with ASD. In other words, there is an inadequate policy approach in organizations, communities, and at the provincial and national levels of government. In Canada, there are no provincial or national lifespan standards of care or policies for this group. This, despite the Standing Senate Committee on Social Affairs that recommended a national policy on autism in 2007. Provincial ministries across Canada do not talk to each other about their autism plans, whereas the United States and the UK both have legislation in place to support national strategies for autism. Adults are being diagnosed or discovering ASD in their 30s, 40s, 50s, and beyond. Our community studies showed that around half of the adults were not diagnosed until they were well within the adult system. If we do not acknowledge this influx of new cases, the public health implications are profound. Coinciding with the identification of new cases, children and youth now being diagnosed with ASD are now aging out of the child and youth system and into the adult system. Many higher functioning individuals have no service provider to transition to. It is as if many diagnostic pathways or lanes are having to merge onto a narrow and insufficient highway. In economic terms, our government is not protecting the investment that we have made in children and youth. One of the recent trends in public health research internationally is to look at the costs of autism for the social and healthcare system. As we heard this morning from Dr. Balkmeyer, in a study by Autism Speaks in the US, it was found that the lifetime cost for an individual was $2.4 million when autism involves intellectual disability and $1.4 million when it does not. Third, the communication system is characterized by knowledge silos. In other words, poor communication and poor knowledge transfer. Accordingly, one of the major aims of the Ontario Working Group is to share knowledge across service sectors. Historically, there's been little communication between adult psychiatry and autism service providers. The Ontario Working Group on Mental Health and Adults with ASD is committed to providing clinicians with information about ASD on our website, through the Portico site, and through other methods. We look forward to offering more in-services, conferences, webinars, and partnering with professional organizations, hospitals, and mental health providers. With respect to the working group's work on policy, our three objectives are to engage LHINs in identifying problems and finding solutions, engage community networks of specialized care, whose aim is to build efficient and effective cross-sectoral specialized service systems that support people with a developmental disability and mental illness. And third, engage health systems and population policy makers and researchers with the hopes of gaining new insights from health systems data in the province. So I'll introduce Marg Whalen, and then we'll go in sequence, and we'll have some time for questions from the audience. And I don't think we need cards in this audience, so please think of some challenging questions for the panel. Marg?
Thank you, Kevin, and I'm very pleased to be part of this panel. I'm going to be talking with you today at a systems level. Our group, the Canadian ASD Alliance, have been working at the national level as non-governmental people to find a meaningful way to work with and influence policy at the federal level. So I need to give you a little bit of history on how that happened. In 2007, probably the most important paper as far as autism and people who have an interest in autism are concerned was published in the Canadian Senate. It was chaired by Senator Art Eggleton, but Senator Jim Munson became the champion for autism and is to this day. And in fact, I have to say that I'm not sure there would be much going on at the federal level with respect to autism if it had not been for the dogged determination and commitment of Jim Munson. That report, which was released in 2007, was the result of a consultation process where a broad range of Canadians of all stripes were invited to make presentations and submit documents to the Senate committee on what they thought needed to be done about autism. Towards the end of that meeting, one of the founding members of CASDA, Laurie Mollum, who was with Canadian Autism Foundation, was kind of pulled aside and was asked by Senator Eggleton, like, what the heck is going on here? There are so many of you who have come here to talk about autism. You've all got a little bit of this and a little bit of that. Can't you just have one voice? Can't we just hear from one person? And then, as the kind of off the record, he said, and if you don't, it's going to just continue to be divide and conquer. You're not going to get anywhere. So it was about a nanosecond after that that Laurie contacted a number of other people. Myself, at the time, I was executive director of Geneva Centre for Autism, Autism Canada, Autism Speaks Canada, and Autism Treatment Services of Canada. And the 5 executive directors of those organizations decided, okay, it was time. We would give this one last try. It wasn't that there hadn't been efforts before, but we were going to give this one last try, and that perhaps the impetus that was created by the Pay Now or Pay Later document would be the thing that would make it catch. And I should say that Peter Satmari and the late Jeanette Holden also offered their support in the early days of that process to keep us motivated to get going. So it was shortly after the report was released in 2007 that we formed the Canadian ASD Alliance for the purpose of advocating with the federal government for the development of an autism strategy, a national autism strategy. Now, it was around the same time, late '07, early '08, that the then Minister of Health, Tony Clements, amid, I'm going to sound a little cynical here, forgive me, but amid much fanfare, announced that there was going to be action on the autism portfolio, that there was going to be this very important meeting, and there would be the appointment of a surveillance team, and there would be the appointment of an autism chair for research into autism, and there were a few other things that would happen. Within very short order, the wheels fell off that bus, and it took a while before we realized that perhaps there really wasn't a firm commitment to release those funds, that the announcement had carried a lot of goodwill, but that maybe that might have been enough. And that was really all the motivation that that group of 5 members of CASDA needed to descend on Ottawa and start hammering away. Now, I do have to say we had a very receptive group of people at the Ministry of Health, and particularly in Public Health Agency Canada. But we made very clear to them that we were not going to let this go, that we'd come too far, there was too much out there in the public domain about this, and that we were not going to let them weasel out of it. I probably shouldn't say that. But in any event, we were successful, to our surprise. And the commitment to surveillance was strengthened, and the decision about the autism chair was reactivated, and CASDA was then invited to have 2 seats on the Public Health Agency of Canada Surveillance Advisory Committee, and also to advise Public Health Agency Canada on the development of the terms of reference and the guidelines for the selection of an autism research chair. That was a huge victory for us. Now, up until then, we'd been very quiet about what CASDA was. We'd had this little group, and we were very purposeful. It wasn't that we were trying to be secretive about it, but you know, when these kinds of things fall apart over and over and over, you learn a lesson that you need to start small enough and get enough credibility and enough steam behind you before you start talking to others about it and ask them if they want to get on the bus with you. And to be fair, it took time for people to realize that they wanted to get on a bus with some assurance that the bus wasn't going to crash again. So I think that 2009 marked a very significant change in that the partnership and the goodwill that existed between CASDA and the Public Health Agency of Canada was very strong. And we were able to help each other in a mutually beneficial way. And there were times that there might have been messages that public health might have wanted to have out there but couldn't, and we could. And there might have been messages that CASDA wanted to get out there that there's no way we could get into the system, but they could. And so a very respectful and careful relationship was built between CASDA and Public Health Agency of Canada. Now I've got this next date on there because I think this is an important element to illustrate how slowly things move at the federal level. And that is something as simple as the proclamation of World Autism Awareness Day. The UN announced this in 2009. It took us until 2012 to get this passed in Canada, despite the fact that the legislation had been written and was ready to be tabled 3 times. We got close to the end 3 times. An election was called, prorogation happened, this happened, that happened, and it was easy for it to just slide off. However, when we did finally reach the promised land, well, you know, when we finally got this done, it seemed really small. But we realized that it wasn't, because what was then happening is that we had a vehicle to bring autism to the federal attention in a very public way, guaranteed once a year. We began to hold Autism on the Hill every April. We began, with Senator Munson's assistance, to host receptions in Parliament, on Parliament Hill, for senators and MPs, so we could talk to them about autism. And it was all surrounded around this Autism Awareness Day. Again, it seemed small, but it was just that thin edge of the wedge that got things going. Around that time, we also began to expand our membership. And I should say that we, in the main, do not attempt to attract parents to this organization. And it's not to be exclusionary, but there's a whole range of wonderful organizations in our country who do this work with such skill. But the piece that we were missing was that systemic process of drawing people together, and out of that emerged what we now call a shared leadership model, which is what drives CASDA. That we are looking to bring organizations together who have that reach down into the broad areas of our multiple communities and in multiple approaches within our communities, but they all are able to work with CASDA so that a single organization can work with the federal government to advance the cause of a national autism strategy. In 2014, actually it was late 2013, in conversations that we had with Public Health Agency Canada, we both came to a place where we realized that Public Health Agency Canada needed some data about what families thought about autism, what the needs were, what the priorities were, but they didn't have a mechanism to get that done on their own. So they submitted, or they put forward a call for proposals for people who would want to develop and deliver a national needs assessment survey. CASDA submitted a proposal and was awarded that project. And it had its moments in that it took quite a long time beyond the yes, we want you to do this, to the here's the money start, but the end date didn't change. So while we had originally given ourselves 9 months to do this project, we ended up having 4.5 months to do it. But in any event, we had a number of things come out of it. One, we had almost 6,000 Canadians respond to this survey. This was, when we put this forward, we thought if we have 2,000, we will feel like we hit pay dirt. We had almost 6,000. The report was, the science part of the work was done by Jonathan Weiss, who is the current autism research chair. And he and his team did a really great job getting the information and translating it into usable chunks that people could understand. So we were able to get that report in on time, and it was formally made public in 2015, early 2015. What we had not anticipated, but were thrilled happened, was that the needs assessment was received with overwhelming positivity. And it was another step in moving forward that role that CASDA could play in partnering with and influencing policy at the national level. So it was shortly after the release of that report that we began to talk to people at the federal level, outside of Public Health Agency Canada, about how to move ahead with this agenda around a national autism strategy. And we were invited to submit a proposal for a model of how this would happen in time for the April 2015 budget. Now, they gave us a week to write this proposal. And they said, don't worry about it, it can just be a draft. But that's never really been our style. So we got our core group together and we wrote a proposal for a $50 million grant to develop a Canadian Autism Partnership for the purpose of having a mechanism that could develop a Canadian autism strategy and implement it, monitor, modify, and so on. Two things happened. They really, really liked the proposal, and it looked like they were going to give us the $50 million. And we panicked because we realized that we did not have the organizational strength or the the strength of a national buy-in to really do a credible job, and it would be really in violation of everything that we had built up until this time. So we went back to them instead and said, why don't you instead give us $2 million, and we will do a national stakeholder engagement process to gather information about this, and then we'll develop a plan and bring it back to you for the $50 million. But we hope you keep the $50 million in an envelope with our name on it. And they said, okay, accept. What they agreed to fund was the Canadian Autism Partnership Project, which I'm happy to, if time allowing, I'll speak a bit about. But it was not to focus on a national autism strategy. That would be something later. It was to look at a piece of it, which is what is the model, what is the mechanism that would enable cross-sector, cross-government coordination to address complex issues related to autism? How do we mobilize resources so that we can come up with innovative solutions, we can make systemic change, and we can fix what's broken? So that's the process that we're involved in at the moment. We are getting ready to launch the stakeholder engagement interviews and online surveys and so on. That will be in April. And if you're interested in knowing more about it or participating in some way, please watch the CASDA website because there will be notices on there. And then we haven't got a CAP website up yet, but it will be up shortly, and it'll give you all the proper links and so on. I could speak for hours about what CAP can do, but I'll just say for the moment that I think it is one of the most interesting opportunities that we've had in the autism field. It's also an initiative that is not going to make a lot of people happy. And the reason I say that is because at the end of the day, the end of the $2 million, and if we get the envelope still, at the end of that, it's not in the immediate term going to mean money for parents who want direct funding. It's not going to mean more ABA consultants. It's not going to mean a shortened wait list. It's going to mean that an effort will be made on a comprehensive pan-Canadian way to mobilize people to address the most complex barriers that we face as an autism sector and get that resolved. Fix the system. Find ways to fix it in a dynamic, ongoing way, not a one-stop thing. We know that won't work. Even if from what we heard from Peter's presentation today, this whole sector is a moving, amorphous kind of thing. We can't come up with a solution right off the top. So again, my caveat about your expectations for the Canadian Autism Partnership is that this is a vehicle for systemic change. The last thing I'll say, and here we go, is why has CASDA been able to do this when all the other things have failed? And I believe it is because of what we call the power of one. CASDA is committed to one voice. We don't talk about other stuff. Our members, when they go to meetings on behalf of CASDA, they don't. I never spoke about Geneva Centre when I ever went to any of these national meetings. If I was there on CASDA business, I only spoke about CASDA. That was the only thing we were there for. We had one goal, and we still do. We have one goal, which is the development of a national ASD strategy. We see the development of a Canadian Autism Partnership as a piece of that. And I think we've reconciled ourselves to the fact that realistically what's going to happen is we're going to get a national ASD strategy by doing it in chunks. We're never going to get the whole thing at once. And the last is that we have one house rule, and we are ruthless about sticking with it. You leave your organization's issues at the door. You're there for CASDA, for that one voice for autism in Canada. Thank you.
Well, hi, everybody. I'm Ian Daw. I'm the Physician-in-Chief at Ontario Shore Centre for Mental Health Sciences. And I had the extraordinary privilege between 2012 and 2014 to be the chair of the Autism Clinical Expert Panel in Ontario for the Ministry of Child and Youth Services. And while that, I think, marked my formal entry into the health policy and advocacy sector. And admittedly, although this is a conference on adults with autism, that was targeted at the child and youth sector. But we were very aware at that time of the transitions that you've heard about all day today, that there was an entire generation of people who were migrating through the age ranges and about to hit the adult sector, and a sector which is admittedly at that time and still today unprepared for those numbers and those experiences. As I was saying, well, that kind of marked my formal entry into the advocacy field. In this particular area, I'd been an advocate for a long period of time. I grew up in Newfoundland. I was a child of healthcare and government officials. I was familiar with the way government thought and worked and saw that intersection of healthcare and policies and how they shaped the actual delivery of services. So in moving to Ontario, that was knowledge that I came with. At the University of Toronto, where I was and continued to be a professor, we were involved in teaching policy, teaching and training our residents and our medical students to be involved, that it was in fact the physician's duty to be an advocate, that they had privileged positions in society as part of their training and their knowledge, that they knew stuff that other people didn't know. They were able to leverage connections and pieces of knowledge and to be that advocate, because although they were doing the business of illness and sickness care, health is not just merely the absence of illness. It's the production of wellness, and nobody can achieve that without being a true advocate. So I was familiar with it. I was teaching it. I got involved early on in working with marginalized and disenfranchised populations. That's the group that I'm always drawn to. It's not a diagnosis. It's not anything. It's people who need stuff, particularly across sectors and across various areas. Because I think once I actually started working in the field, I saw very quickly that silos existed all around. We talk about busting silos, and we've been talking about busting silos for nigh on 35 years. They continue to exist. And as a point of care professional, I think it really struck me of seeing, both in my clients and from another perspective I'll share with you in just a second, of all the reasons things didn't work. And I thought, if I ever get the chance to be given the keys to do something, how could I ever in good stand criticize something ever again if I turned that opportunity down, if I didn't actually volunteer to be part of change. And all that, was fine and good. But truly, the reason I got involved in the autism sector is I'm the parent of an autistic boy. born in 2000, now just about to turn 16. My God, I can't hardly believe that. It's terrifying. But I had that knowledge. I got to see firsthand what that was like, the struggles of wait lists, the ideas and the terror of waiting and waiting and waiting and waiting, and then once you finally get to the top of a wait list, being terrified again that you'll time out or that you'll be discharged. And that was knowledge that I carried with me for a long time. Yeah, I'm aware of how difficult and the impacts that it occurred. It almost bankrupted our family. You know, despite the privileged position of being a physician, it certainly broke up our family. There are tons of scars that come with that experience, and it always came from that notion for me that although we talk a lot about in healthcare lived experience and the value of lived experience as we form relationships with our clients and families, it's actually not lived experience that counts. It's lived expertise. So I always catch myself in trying to shift that format, because experience is one thing. What families and caregivers and providers and people bring is the expertise of their lived experiences. So that has been a tremendously influential aspect. So I wanted to tell you a little bit, because all of those things came together for me in about late 2011 or so. I was sitting at my desk at Ontario Shores, and I got a memo asking us to consider appointing someone, or at least recommending someone, to a newly founded government clinical expert panel. And this panel was going to be constituted to review the clinical benchmarks and the expert consensus guidelines for the practice and the delivery of autism services in Ontario. Those things had been recommended and endorsed by previous expert panels, but had never been formally enacted in the province. So they were asking now for an update on the research of those things and how to actually implement them. Ontario Shores, like some of our other specialty hospital partners in Ontario, has an autism treatment unit. We have 10 beds focused on dual disorders, the construct of autism plus mental health concerns. And we'll come back to that in a second. I recommended one of our providers who turned down the opportunity because he was so busy and so overwhelmed actually being the point of care person and meeting the needs of those populations. He literally had no time to participate. So in a fit of frustration and a peak of anger, I said, damn it, I'll put my name forward. I just filled it out and put my own name forward, never expecting, in fact, that I would get the call. And not only did I get the call to be part of it, I got the call to be chair of it. I was very worried at the time that my own lived expertise would somehow count against that I would be seen in a conflict of interest perspective, or as we've just heard, that I would be bringing my issues to the area. And they said, actually, no, that's not a problem. That's what we want. Not your particular issue. We don't want you to be the sole representative of parents and families. But that's a good perspective to have, to just be aware of. So I said yes to the opportunity, and we started off our work. We went across the province. We were one of 4 public consultation efforts that was taking place at the same time. In the developmental sector, a couple of other places in the autism treatment world, were all interviewing Ontario parents and families at the same time. And Ontario families, as you well know, have been giving their perspective on autism for many, many, many years. And here they were now, all concurrently being asked by 4 separate panels, hey, what do you think about autism in Ontario? And boy, we heard it. We heard lots of things. For us, it was really about working on the delivery mechanisms, because as we've heard, there's so many things about this that doesn't work. And some people were lucky enough to get into IBI treatments and therapies, and then they stayed in for a very long time. And there was really no mechanism to move those people or even to evaluate whether those people continued to need IBI-based services. And from a flow perspective, when you start talking about how to offer a heavily intensive and costly service to a population, you need to have people moving in and moving out, because there isn't limitless budgets and limitless providers. But there was really no mechanism to judge how to do that. And that's what we started to talk about, is to look at benchmarks and practice guidelines, standardizing those things across the province, because in our consultations we heard repeatedly that autism services in Thunder Bay were not autism services in Burlington, which were not autism services in Ontario, wherever you happen to put the pin in the map. It was different. It was all over the place. So we talked a lot about how to standardize those things. And clearly, we talked a lot about trying to move away from just the single focus on IBI, that in fact there was a whole bunch of slightly less intensive services, the ABA-based services, that parents and families weren't taking into account as a viable piece of the puzzle. They were being presented to it as an alternative to IBI, or, I'm sorry, you don't get IBI, but we can give you this thing. That's not the way to market ABA. ABA is a valued and important piece of it. It's not some kind of consolation prize. So we talked a lot about how to build a continuum of services. And in something that continues to really influence the work I'm doing now, we talked a lot about actually not waiting for a diagnosis, that a diagnosis-based service, by its very nature, creates roadblocks and creates delays, because you're waiting for very limited and hard-to-access professionals to do assessments before somebody can receive the treatment. So we made recommendations that actually opened up service delivery to people who were red flagged just on the basis of symptoms as opposed to the diagnosis. Finally, the thing that I'll share with you as I wrap up is the work that we're doing within Ontario Shores as well. Because as I mentioned, that is focused on the adult population admittedly with mental health concerns. But of those 10 beds, the average length of stay for individuals occupying those beds is about 2.5 years. They were declared, and this sounds horrible to refer to people in this capacity, but they were declared ALC, alternate level of care, meaning that they actually didn't require hospital-based services about 6 months into that treatment program. The actual treatment got done very, very quickly, and their circumstances and situations and behaviors improved to the point where they could be discharged. There was no place for them to go. That's why they're ALC. That's why they continue to be in the organization. They are finding the home in the hospital, because there isn't the services in the community that can step up to meet that level of intensity and that level of need. There was huge gaps between what the long-term care providers could offer, some of the community-based homes, the group homes, and the hospital, and there was nothing in between. There still is not much in between. But a lot of the advocacy and policy efforts of myself and our colleagues now is focused on trying to close that gap, to look at different ways of providing services that are somewhere between what the hospital can do and what the community can do, because there is clearly an extraordinary need for it. And just as I said earlier, when we were talking about the youth population, you can't have a good system that doesn't have flow in through a front door and out through a back door. If you close one of those entry points, the system breaks down by default. So we were very much and continue to be very much focused on it today. When we submitted our report in 2014, of course, we were deep into the deficit of the province. We're still in that as of yesterday, not quite as bad as it was last year. And we were pleased to see some recommendations of increasing hospital budgets, $300 million to autism services. I like to think we had a little bit to do with that. It's just been shelved for a couple of years, but it's starting to come out now. And I think you'll see some of the efforts and advocacy that we made, and so many of the other people were making, as you've just heard before me. To get involved in policy means that you have to be diligent and you have to have delayed gratification. You need to be able to be at this for years and years and years, and be willing to invest that time and wait for the successes. I think the future is brighter than certainly what the past has been. It has not been through lack of effort that these gaps have been worked on and are starting to close. Still tons to do. I invite all of you to join us on this panel, on this side of the room, as advocates and as change people in the system. But we're getting there. Thanks very much.
Okay, so you don't have slides from this. That's okay. I'm delighted to be here today, and I'm very glad that those of you who showed up for this section did, because that means you're interested in the conversation that was just mentioned that's happening on this side of the table. And that that means as a result you're participating in changing what happens in this province, in this country, in terms of supports for people with ASD. The slide that I wanted to show you was one that really showed across the lifetime of persons with ASD. And the reason I wanted to bring that slide to your attention was to really remember that even though we're talking about adults here, every conversation about adult supports involves thinking holistically about families from those very early years throughout the entire life of that person, not only of the parents, but of that person through their more senior years. And that everything that happens in those early years ultimately will influence some of the choices we need to make that are necessary in supporting adults. And I think even the announcement about the funding yesterday just reminds us that even that has shifted in our thinking and where the funding is going to go, and forever moving more towards evidence-based approaches. And I think as we do that, that should inform also what we learn about supporting adults with ASD. I wanted to let you know also about a survey that Autism Ontario conducted right around the same time that the CASDA survey occurred. And our survey was for purposes of really thinking about families who work with Autism Ontario, but who are also interested in letting us know as a province what are the things that matter most to families. So we had 1,750 responses, which isn't bad for Ontario. And 75% of those were either from parents or from a caregiver of a child with ASD, and 22% were from parents or caregivers of an adult with ASD. And we did that thing where you leave an open area for comments on a survey. And for us, that means in the field of autism, you know what's going in that space. And there was no restriction on the limit. So, which is delightful because you hear everything. But it's quite an effort to take a look at that and find those common themes. But what I wanted to let you know is that what's interesting to us is even though the majority of people who responded were parents of children, the most predominant theme was on the comments on asking us about what we should be focusing on as a province was on more teen and adult supports. So it didn't matter. That wasn't coming just from people who are in those adult years, but indeed from the parents of children and those younger folks. So that was really important. The other thing I wanted to mention about thinking in terms of healthcare is that 87% of the respondents that use healthcare professionals for information on ASD, only 39% considered this information useful. So that was really striking in terms of what we could say definitively about from that survey. So that just tells us we have a long way to go in educating our healthcare community. So a conference like this matters enormously. The other thing we asked people is about what was missing in their area and what are the kinds of things that they really needed to see more public supports for. And of the 864 comments that focused on those themes, we looked at some of the key things, but really what it turned out to be was a dump of we need everything. But looking at just the first 300 comments, employment and vocational training, job coaching, all of the issues related to getting employment were number one on that list when we pulled from those themes, followed by ABA, so evidence-based practices, family and parent supports, things to do together as families, getting together with sibling supports and groups that allowed people to be together, then social skills and social opportunities, ways to do those things together and better. And then adaptive skills and life skills and program opportunities. That list went on with a number of things gradually decreasing, but they were all in our top 10. Respite services, addressing the whole range of abilities, not just one area of ability, really everything. And that comment came out, I would say, with the most colorful language. Training for families, webinars, more professional training for the folks who they're not finding able to have answers. And that transition year, obviously, those transition years are key, and a sense of weariness and despair. And it wasn't even so much a theme about what do we need, but it got stated so often, I felt we needed to share it today. And they don't know what's available. That was the other comment that we were in some ways surprised, in other ways not. There aren't a lot of things available, but people weren't even sure if they knew that. The other thing I wanted to shift to now is to think a little bit about what is happening about getting some of these messages out and going forward. So we work in Ontario with a group of us who have been together since 2006 called OPA, the Ontario Partnership for Adults with Asperger's and Autism. And that represents the larger autism organizations, specifically autism-focused organizations in this province, who are thinking about ways that we can speak to government about what those families are telling us in many ways through the results of surveys like CASDA. There are so many common themes. We could probably do a study just on replicating these kinds of surveys to say these are consistently represented issues. But that there is a need for comprehensive, accurate cross-sector data collection. And that last year we know that there was an $810 million allocation made. And that in community and social services was significant, but it won't solve those widespread cross-systemic problems nor provide necessarily for many new services. Having said that, the housing piece was one notable exception. And you heard a little bit about that this morning, so I won't belabor that point, but it's an important one. And that housing piece came together because of the voice of parents. And I cannot underestimate that in any way or understate it, or overstate it. It needs to be the kind of thing where you have that partnership between family voices and the folks who are looking at how do we change systems to make a really significant change. The other thing we've been looking at really is that looking at eligibility for adults with ASD and the IQ issue that was discussed this morning as well, and people being excluded from DSO criteria for passport funding. It's a significant area. We have been clanging that gong quite consistently, and it's one of the areas of focus that we represent wherever we go with our messages, in speaking to the Ombudsman's office, in speaking with service providers, in trying to examine where are those gaps, who's missing out on those opportunities, and if not that door, then which door? So if it's not going to be DSO supports, where else can we go, particularly with the mental health challenges that we know over 50% of adults with ASD experience? And so those are some of the key things. And I would say the last thing that we talk about a lot is looking at the variety of medical conditions that are present in autism, and that providing those supports should not be discretionary. We need to make sure that the health of all Canadians, including those with ASD, are well supported and that they have trained professionals they can access, who understand that can be received easily by the families and the individuals who need those supports. And as a result, we need the Ministry of Health and Long-Term Care to be actively involved, and that is critically important. There are a number of really promising programs that are happening in the province. I'm not going to spend a lot of time on those, other than to say that we do have good ideas about where some evidence is either promising or showing that we can make a difference in the lives of people with ASD. And those include peers programs, the Transition to Life program that's occurring in the province, social skills groups that are being led in various parts of the province that are showing some good evidence. Looking at various projects that we've been working on where we're trying to educate the public about who people with autism are. We've just been involved in a really exciting project with some funds from Autism Speaks Canada, who've helped us to produce the video that was led by Michael McCreary, and some of you attended that session. I don't know if any of you have had a chance to see that video yet, but if you haven't, I urge you to go and see it on our website or on his website or others at this point. It's been very popular, but it's a way to help educate quickly in about 7-8 minutes something about what ASD is to business professionals, to health professionals, to law enforcement professionals, anyone who can really, who needs to understand in a nutshell what that is. And I think those key things matter tremendously. The last things I want to wrap up with is that we are looking at a number of, I've mentioned the Housing Task Force, so these are some promising Ontario initiatives. The work from HCARD, I don't know, I think it's been mentioned a couple times, is important, the DD Cares model. This was mentioned this morning as well. But that kind of work really helps us identify some of the healthcare needs of people with developmental disabilities, including autism. There was a meeting just this past week gathering with some of that data and looking at what could we possibly do to move things forward in the area of healthcare changes for people with developmental disabilities. You're going to hear from Jane Cousins about a really promising program that's been working. And the last thing I want to mention is that even though we focus and talk about ASD, I had an opportunity to attend on a conference back in the fall from the Canadian Mental Health Commission. And they were producing a consensus paper on emerging adults with mental health needs. And what was interesting about that conference is that in a room of 250 people from across Canada talking about mental health needs, not once in any of their documentation was there a reference to developmental disabilities or autism. And yet, we're seeing some really positive change and growth in the area of mental health awareness and supports, but we're not talking to each other or hitching our carts to one another, and that needs to happen if we're going to create those systemic changes. And so it was interesting to be present and to be the lone voice about autism. Actually, two of us were there, from a representative from CASDA as well. And so we made it our business to go around and stuff the box, as it were, in every place we could, which is what you need to do to get your voice heard sometimes, right? And so I want to encourage all of you to think about that. One other thing I want to encourage you to think about is that on Monday, there's a deadline to respond to this document called Patients First. And so you can go right online and drop your comments in on the website. But check it out. And this is another place where we can get some messages to the folks at the Ministry of Health and Long-Term Care about what it means to focus on patients first. And that includes people with ASD. So be active and involved. So if you're not actually having an opportunity to be on a committee, you can do something like this as a citizen and respond as an individual, as an organization, which we will do as a group with OPA. Or you can do something like join a Raise the Flag event on World Autism Awareness Day that Autism Ontario is supporting across the province with support from BMO, we mentioned this morning. And I'll stop there. Thank you.
When I grow up, I want to be a firefighter, said a group of very excited 5-year-old boys. When I grow up, I want to be a teacher, said a group of excited 6-year-old girls. When we grow up, we want to be a zookeeper, said a group of excited 7- and 8-year-old boys and girls. When I grow up, I want to be actively involved in healthcare policy, said no one, ever. Really? No one? Surely healthcare policy has the adventure of fighting fires, the educational opportunities of being a teacher, and even the nurturing of being a zookeeper. And yet we don't think of it as kids. Heck, we don't even think of it as adults. However, work in healthcare policy, particularly as it works to advance the care and consideration of services of people that you serve or advocate for, is actually the work of all of us. as we think about policy as an instrument for change. It's an honor to have been invited to be on this panel with such an esteemed group of co-presenters. The first question we were asked to address on this panel is how we became involved in policy. My journey is certainly best described as that of a very accidental tourist. Like most healthcare professionals, I joined my field because I wanted to help people. For me, that meant the privilege of training in clinical psychology. And what I quickly learned is that while you can help individuals, families, and groups, you can certainly also do work on another level of change. It was the link of clinical services to research, or more specifically in my case, to evaluation research, that started my understanding of why healthcare providers not only should, but need to, get so very actively involved in policy. As many of you know, evaluation research uses many different methods, evaluating if something has made a difference, its impact, but it's also a really powerful way to evaluate the needs of a group that have not yet been heard or determining the need of a service. It's through evaluation that we've developed our unique mental health team and the focus of what I was asked to talk to you about today. In 2012, 6 hospitals in Ontario were part of a provincial review that was commissioned to look at the issue of long-stay hospitalization, something Ian spoke about with folks with a dual diagnosis. Well, it didn't take very long to think about why people are in hospital for elongated periods of time to realize that you can't study hospitalization without understanding the whole continuum of care, or more importantly, understanding all of the parts of the continuum that are in fact missing to create a meaningful continuum of care for folks with dual diagnosis, autism spectrum disorder, and mental health needs. What we already knew is that individuals use other parts of the service system with much more frequency, emergency rooms, emergency services, and episodes of care that don't necessarily lead to long-term support or meaningful change. In fact, my LHIN, the Champlain LHIN, I live in Ottawa, was in fact the only LHIN at the time that had absolutely no treatment services available for people with a dual diagnosis. At the same time that we were rolling out these findings and recommending a continuum of supports and services for people, one of my residents and I did a needs assessment in our city to try to understand the needs of people with ASD and mental health challenges. What both of these evaluations, the provincial review and the local needs assessment, told us is something that many of the people in this room know. Services are often not flexible enough to meet people where they're at, in their locations of comfort, not able to titrate to their needs, and there's not usually enough care or the wrong type of care available at the wrong time. There were lots of levels of care to bounce between, but you needed to be a very skilled cartographer to understand the map of what was available. One of the things that we often found was that care was provided in isolation, without the richness of a multidisciplinary team, and when people needed to change levels of care, particularly as adults coming into the system, there was less available. These were 2 key steps for us, and it was really the first opportunity we had to actively challenge ourselves about how to learn to develop a flexible model of care. We knew what we had found was an important set of needs or problems, and it was unique enough to not be met by regular models of mental health care, even community-based ones that we had, but we need to think about how to be much more flexible. We had the opportunity to learn from an international neighbor. In the Netherlands, a model of mental health-specific care was being rolled out called FACT, or Flexible Assertive Community Treatment. It was a model for adults with mental health needs, and it was based at the neighborhood level. It was designed to be something a little bit different than the ACT teams that we already had in our program. It could have the intensity of a 24/7 ACT team, but also the flexibility to offer case management or things that were less intense. Importantly, that flexibility existed on the same team with the same providers, that continuity that so many people with autism spectrum disorder crave in the delivery of their services. So community-based, flexible to need, sounds like the answers to all of our identified needs, but it was hard to convince the Ministry of Health in a 0% climate. So we made a proposal to try to adapt the FACT model, the first time it's actually been done in Canada, to serve 2 different geographies, our urban center, but also regional satellite offices. And we were thrilled to be funded, but just for the urban center by the Ministry of Health. We had developed this proposal, however, with some wise guidance from a Ministry of Community and Social Services rep, a lot of parent groups, and other community agencies. So to our delight, when the Ministry of Community and Social Services approached us to fund our regional offices, we were truly thrilled. We would suddenly have an urban and a rural model of service, and we'd suddenly be able to cover a large geography with a flexible interdisciplinary model. But then came a small catch. The catch has been talked about many times already today, and this is the issue of DSO eligibility. So this team requires folks to have the presence of an intellectual disability, as well as a mental health challenge. So, with the caveat of inclusion of intellectual disability, we know that a conservative estimate is that we will capture perhaps 50% of the population or more that we need to capture, but miss many others. It brings me back full circle to my point about evaluation research. The exact needs that we assessed and tried to understand and measure to get us to this point are the ones that we'll need to work with this room and others to continue to capture who could have been served by our model, but won't be at this point until we're able to expand the eligibility criteria. So why does this matter to a room of clinicians, a steering committee of family, community partners, or a room of advocates like here today? I think it's because the story of a team development like ours runs a great risk of being stagnant if we don't engage in the policy debate and in policy development. The issue is not how do we deliver an innovative model of care. The issue is how do we use it to promote wider policy considerations in meeting the needs of a broader group, namely those with ASD and mental health challenges without intellectual disability. There's also the issue of challenging policies of inclusion, or better stated exclusion, for people with ASD and mental health challenges in mainstream services. Those that want to be in services should not suffer what we often call benign neglect, or services thinking they'd like to help, but they don't feel equipped to help, so in fact they'll just exclude folks with ASD. Interestingly, we as clinicians and advocates know these issues, and yet we often shy away from the policy arena. Worse, we don't empower or teach others about how to engage in policy. So our voices of experience are silent because we haven't been taught how to sing that song. One of my most enjoyable roles is the opportunity to teach psychology and psychiatry residents. We teach a myriad of clinical skills, research skills, evaluation, and consultation, but we often fall short of fully teaching how to critically engage in policy discussions, particularly for the purposes of advocating for change. In medicine, the CanMEDS framework of the Royal College defines the health role advocate and others, and Ian spoke to this a bit, but we still have not fully engaged and empowered everyone to be powerful advocates and speak from their clinical voices as well as the collective voices with the community. In fact, when I looked through all of the graduate curriculums in healthcare, I could find just a bit of a mention of policy work in social work curriculum. It needs to be in all disciplines. We as healthcare professionals and advocates are often the ones who say we'll leave policy to the bureaucrats, stating it's not for us. But instead I challenge us to say, how could it not be for us? We've got rich clinical examples in our daily work. We create and deliver meaningful services, and we can collect rich service evaluation data. However, in simply bemoaning what something doesn't work, we need to challenge ourselves to engage with policymakers, to have influence, and to in fact offer to help pick up the pen. Some months ago, I ran the high risk of also being an armchair critic when the guidelines for managing severe and challenging behaviors in dual diagnosis came out. And so I took the advice that I'm trying to deliver today and speak more broadly about in my community and became actively engaged in the policy writing process. I learned a great deal. I learned that when I'm in a clinical situation, if I'm trying to speak to a client or a family, that they don't speak my language, I don't just raise my voice, disengage, or walk away. It's my job to make myself heard and understood. The same happens in a policy arena. I need to change my clinical voice so that I can be heard in other ways. That's the type of speaking that we need to start doing. I used to think that healthcare professionals being in the policy arena were like fish out of water. And now I challenge us all instead to see ourselves as learning to swim in new ponds. There's tremendous potential for the services and opportunities that could be available to individuals with autism spectrum disorder and mental health challenges if we all work together to build the right systems of care. But just like we're not trying to ask individuals with autism to change to meet the services we've got, We need to ask policy not just to change, to guess what we need to get engaged and help it change. We need to share our perspectives and to contribute to that. Perhaps one day the best and the brightest among our trainees will in fact understand the adventure, education opportunities, and caring available not in being firefighters, teachers, or zookeepers, but in being the writers and analysts of progressive healthcare policy. Until that day, when a grade 3 classroom can get that excited about writing policy, let's make it our job to do it together. Thank you.
Good afternoon. My name is Jane Cousins, and I work with the Ministry of Training Colleges and Universities. I have to say that on that grade 3 schoolyard conversation about what would you be when you grow up, I would be that policy geek. I've loved and been fascinated with the decision-making processes used by governments and diverse communities when they come together and identify goals, develop plans, and design programs. This lifelong interest came for me from childhood growing up for a while in Lagos, Nigeria. In the early 70s, there were 2 million people, hundreds of thousands of cars, and not a single traffic light. So the whole decision-making process became quite fascinating. After 26 years in government, I still find the collaborative and creative aspects of policymaking quite fascinating. And over the next few minutes, I'd like to tell you about one of the more exciting projects I've been involved in, the 4-point action plan to strengthen transitions to post-secondary education for students with autism spectrum disorders. The ministry has led this plan over the last 3 years. And in telling you about it, I would like to highlight a few of the themes that have run through my fellow panel members' conversations. The importance of grassroots input and advocacy groups articulating what key issues are, the importance of collaboration across sectors, and the importance of the direct involvement of students with ASD and of family members in the design of the decision-making processes. So in February 2014, the Ontario government announced the investment of $1.5 million in a 3-year action plan to inform the development of transition supports for all students with disabilities as they move from high school into colleges and universities across the province, with an early focus on students with ASD. The focus of the plan was on the design, testing, and the evaluation of a proposed transition model, and we're on track to see results by the summer of 2016. From the onset, grassroots input raised our awareness of the needs for the transition supports and also of students on the spectrum. Advocacy groups and post-secondary institutions both shone a bright light on the dramatic increase in the numbers of students with ASD and on the needs of those students. The research showed an increase in the number of students graduating from high school and entering colleges and universities, a trend that has continued over the last 5 years, with that number quadrupling from 400 students to over 1,600 students. In 2013, district school boards reported to the Ministry of Education that they were providing special education programs and services to almost 18,900 students identified with ASD. This compares to slightly more than 5,000 students supported in 2002-03. The ministry heard from colleges and universities of the need to develop intensive and unique supports and services for these students in areas such as dealing with increased anxiety, social integration, and time management. In December of 2013, the Geneva Center for Autism and York University partnered to host a conference on transitions to post-secondary education for students with ASD. They invited 250 stakeholders, public servants, of which I was one, from across the sectors, and they brought in experts from across North America to talk about key issues and best practices. And a lot of us really got up to speed on some of the issues from that particular conference. Collaboration across the sectors has been built into the design of the 4 points of the action plan that followed. The Ministry of Training Colleges and Universities led this plan, but in collaboration with 4 other ministries in Ontario and their sectors: the Ministry of Education, of Children and Youth Services, the Ministry of Community and Social Services, and the Ministry of Health and Long-Term Care. I'd like to talk with you about the 4 points in the plan, which included, firstly, the launch of a transition resource website. Secondly, the establishment of 2 demonstration projects, one led by a college and one by a university in partnership with district school boards. Thirdly, a multi-sector working group was pulled together and tasked with advising on a transitions model. And then finally, the final point in the plan is a review of documentation and best practices for that transition process for students moving from high school into post-secondary education. So point 1 in the plan, in a bit more detail, in December 2013, an online transition resource guide was launched to provide information to all secondary students with disabilities making the transition to Ontario's 20 universities and 24 colleges. It can be found at www.transitionresourceguide.ca. The ministry looked to Queen's University's Regional Assessment and Resource Centre to increase the capacity of a newly developed site, develop a French language site, and add resources for students with ASD. They integrated collaborative processes into the management of the site through an advisory board drawn from the community groups and post-secondary institutions. That site now averages 2,000 to 3,000 visits a month and has distributed about 2,000 hard copies to guidance offices across the province. Point 2 of the plan, announced by the government in February 2014, was the launch of 2 demonstration projects. One was led by Algonquin College in partnership with the Ottawa Carleton District School Board. We have people from that pilot here today. And a second was launched at York University in partnership with the TDSB and York Catholic District School Board. The projects were asked to implement and test a proposed transitions model for students with ASD. In developing that initial model, we built upon the success established over an 8-year period by the Ministries of Education and Children and Youth Services through the Connections model that they had worked on with stakeholders and had been highly successful in helping to transition young children into elementary schools. Each post-secondary institution has received up to $240,000 per year from my ministry, and the coordinating school boards have received a total of $270,000 through the Ministry of Education over the 2 years ending in December 2016. By the spring of this year, the projects are expected to provide advice on a transitions model for students with ASD, as well as proposed best practices, tools, and supports for students with ASD transitioning into post-secondary ed. Proposed practices for the development, as well as proposed practices for the development of partnerships and how to establish and support partnerships between post-secondary institutions and district school boards and with community agencies to support the transition of these students. They're also being asked for input into a conference to be held in the fall of 2016 for the sectors to share best practices. Each coordinating school board, with the involvement of other boards from the region, has been asked to review their current practices to identify gaps and set targets to strengthen boards' capacities to implement a transitions model. They've also been asked to participate in professional learning communities, develop resources and support documentation, and provide recommendations for province-wide implementation. As you can see, the plan was designed to include students on the spectrum and family members of students with ASD in the demonstration projects. The ministry was also strategic in asking students and alumni, as well as a family member, to participate as members of the working group. And I think we have we have a few people from the multi-sector advisory group here. Its mandate was to, and is still, to advise the Deputy Minister of MTCU on this transitions model for students with ASD. There were a total of 33 members invited to participate in the group from across the sectors based on their experience and expertise on transitions for students, as well as their experience living with ASD. In addition to the 2 students and a parent, the group included representation from secondary and post-secondary institutions, community agencies, and healthcare providers, as well as the staff from the 5 ministries involved. This group has met 4 times, and their input and participation has brought what was referred to earlier, but is truly real lived experience to the discussions of the panel. The students and the parent have helped steer the conversation to consider issues from the perspective of a student, and to ask the panel members to do that as well. And issues such as stigma and the complexity of applying for forms through the OSEP program have been raised as concerns through that process and at that table. So the final point in the plan is a review of transitions-related documentation for students with ASD. The ministry again asked the Regional Assessment and Resource Centre at Queen's and the 2 demonstration projects to offer specialized psychoeducational assessment designed for students with ASD to the participants in the 2 projects. The responsibility for identification of documentation requirements for accommodation does lie with colleges and universities, so the results from the use of these assessments will support consideration of the need for and options available to improve such things as communications about the documentation required, and to enable students to be better prepared to make that transition to post-secondary education. In conclusion, the key elements of the action plan have benefited greatly from each of the themes raised here this afternoon, and I think have positioned us to see good results as the results of the plan roll out. Certainly from early information we're hearing, the 148 students with, or probably a bit more than 150 now, students with ASD and their families have participated in the 2 years of the demonstration projects. Their ongoing feedback has informed the post-secondary institutions and school boards on ways to improve the projects. The fact that 83% of these students enrolled in the first year of the project were able to complete their academic year indicates this work seems to be on the right track. In addition, the advisory group members are poised, I think, to assess the results, evidence-based results from the 2 projects, and when they meet in May to put together advice to the Deputy Minister on the model going forward. We at the ministries are looking forward to seeing the results of this project. Thank you very much.
Wow. I am so excited about this policy discussion because we're really talking about systems change that we as clinicians, practitioners know needs to happen in our province and our country. So it is, however, Friday afternoon at almost 4:30, so I'm just so impressed and invigorated by this discussion and input by the panelists. Thank you so much. So this is a very quick opportunity for you to ask some questions of the panel. I have some questions of the panel too that I'd like to ask. So and we can be informal here, and you can just raise your hand. I'd ask that the questions be short and clear and to the point. And if you want to have longer discussions with any of us, we'd certainly invite that. Okay, Ginny.
This is for Mark as it relates to something you were saying
Get
about
Ginny, can you stand up?
Oh, sorry. This relates to the strategy, the national strategy, and the fact, being a federal employee, I understand, the arrangements, terms, and proposals, and I understand policy. And with when you talk about the national strategy, I'm hoping that, you know how you said they're chunking things, that we don't just go chunking for the children, that we make sure we're adamant that
everybody hear that question? Are you, okay. So the answer, I want to reassure you that yes, that will be included. It's next, we have a position paper on the CASDA website that talks about the various areas that we think are top priority. It is in the process of being updated, particularly as we have a new government and we've done a review of the mandate letters of the various ministers. So we're tying those in. What I meant by that we're trying to chunk it down, we realized, and we got some good advice from insiders who are saying, you know, as long as we're talking about this, they're never going to talk to us. We've got to find out how to prioritize the pieces, but not lose sight of the long game. And I guess that's the piece that is both frustrating but is absolutely pragmatic, that this is a long game. It took us 9 years to get to this point where I can say, you know, we've really got momentum going here. Starting with 5 members, we have now 150 members, and they represent every major autism service provider across the country. So the other thing is that in the National Needs Assessment that was published in 2014, the mental health issues of adults was a very, very prominent issue that was identified, and so it has been, it's like up near the top of the list. So I can assure you that yes, that will be attended.
Thank you. Yes?
I have to commend the panel for excellent presentations. May I just say the health system asks and accepts millions of public money to finance practitioner salaries and indeed ASD programs. Yet from this morning's, the private sector, Tim Hortons, is acclaimed for providing minimum wage to 6 people with disabilities. There are so many sections of society demanding their rights for all kinds of reasons. Why can't CASDA petition the government for a higher wage and profile, not a minimum wage for their disabilities, and taking them to celebrity status as a barista?
That's an excellent assessment of our current situation. Thank you. CASDA is involved in a number of employment and employment training initiatives at the moment. This is a very slow process because although I don't think you'd find anyone who disagrees with the notion that minimum wage is not enough for anyone, it's novel that, not good enough, but nevertheless it is novel that people with ASD are getting into paid employment. So, I mean, we have a very long way to go, but I agree with you that this is an area of advocacy that we all need to be pursuing. Thank you.
Thank you. I have a question about the role of the LHINs in policy shaping and development, and I wonder if maybe Dr. Daw can start off that discussion, because I think that that's a really underutilized resource when it comes to thinking about policy change in ASD.
Sure. I didn't mention it, but one of the other kind of hats that I've been wearing for the last couple of years is the mental health and addictions physician lead in the Central East LHIN. So a fairly big and very geographical area, both urban and rural. And I think LHINs do have a very important aspect that they can help shape the regional delivery of services. They are focused, admittedly, on sectional work, on what's happening in the local communities, and trying to bridge the broader swaths of policy and the development of services that come out from best practices, and to apply them into the local jurisdictions. But as we heard, that in the U.S. and in other countries, there is legislation that really promotes the kind of cross-state conversations and cross-ministerial conversations. There isn't any such thing in Ontario. And LHINs themselves, although they have informal ways of sharing networks, they very much are concentrated on the individual delivery of services. We often think of LHINs purely as a flow-through agency, that they receive money from the ministry and then kind of distribute it outwards. But in fact, they have very important roles to help shape how that money gets distributed, and whether they choose to put conditions on some of the agreements with providers and organizations or direct it in subtle ways. There are opportunities for engagement there. I think in Central East, we've actually accomplished quite a lot over the last couple of years by working with the LHINs, not against the LHINs, or not treating them in a passive kind of phenomena. So I think when you start to look at how things are happening in local communities, the LHINs are a very important aspect of that. We need something that actually helps standardize those approaches to reduce the variation, of course, across the province, because there are 14 different LHINs, there are 14 different ways of looking at those things. Perhaps not going to be 14 in the future, but we'll see. We want something that actually has local influences, but standardization across the broader populations.
Thank you. One last question.
Just to add to your comment, do you think the sub-LHIN model is going to help with that?
Maybe. I mean, it has possibilities. But again, it's all about, I think, the execution of how those structures actually work, where they receive their information, how they're influencing the practitioners, how the practitioners are influencing them. I think it remains to be seen.
Yes.
I was just wondering, since the LHINs do exist right now, and as Dr. Farrell was saying, Champlain LHIN has really been deficient in dual clinics. Where do you start? What buttons do you push if you want to change that?
You want to try that one first?
Can somebody repeat the question, because I didn't hear it either?
The question was, where do you start? Who do you start pushing buttons for if, in fact, you identify that there are local deficiencies of services?
Yeah, absolutely. I mean, there isn't a magic formula. What we did was we looked at the individuals who were well known in our area, receiving expensive care but not the right care. And it didn't take very long to line up the bill of service for that group of people and then talk about the new team that we were proposing as actually being quite a good deal by comparison.
So economic.
Yep. It didn't hurt that I'm married to an economist, and he finally said, you know, enough with the good intended clinical discussions. You need to start having an economic discussion.
Okay. I'd like to conclude this session. Thank you again, panelists, for your comments. One of the things that I'm working on and thinking about as the leader of the Policy and Advocacy Subcommittee of the Ontario Working Group is to complete a review, a national review of policies related to adults, youth and adults with autism spectrum disorders. And I've been planting the seed in Ontario and also this week in BC when I was out there for a meeting. So stay tuned, and please do not underestimate the value of one united voice and greater access to mental health care for youth and adults with ASD. Thank you very much.